So let's read about the abnormalities of chromosome structure. The structure of chromosomal abnormalities includes deletions, duplications, translocations, isochromosomes, inversions, R or ring chromosomes, and mosaicism. Identification of a structural chromosomal abnormality in offspring raises two primary questions. First, what phenotype or later developmental abnormalities are associated with the findings, and second, parental karyotype evaluation indicated or not. So these two questions arises. In other words, are the parents increased risk of carrying this abnormality, and if so, what is their risk of having future affected offspring? Coming to deletions and duplications, a chromosome with a deletion has a stretch of DNA that is missing. So what is deletion? When a stretch of DNA is missing. Whereas duplication, when there is a region which is included twice. So deletion and duplication, most deletions and duplications occurs during meiosis and results from malalignment or mismatching during the pairing of homologous chromosomes. This misalignment segment may be deleted, and if the mismatch remains when the two chromosomes recombine, it may result in deletion of one chromosome and duplication in the other. When a deletion or duplication is identified in a fetus or infant, parental karyotyping should be offered. So this is a situation where we offer parental karyotyping, because if either parent carries a balanced translocation, the recurrence risk is significantly increased. Deletions involving DNA segments large enough to be seen with standard cytogenetic karyotyping are identified in 1 in 7,000 births. Common deletion may be referred to as aponium, such as deletion of 5p or 5th or chromosome number 5 short arm. This is associated with Cry-Du-Chat syndrome. Microdeletions and microduplications. So what are microdeletions and microduplication? When a duplication or deletion is smaller than less than 3 to 5 million base pairs. So if the deletion is between 3 to 5 base pair or less than that, then this is known as microdeletion or duplication. It is too small to be detected with a standard karyotype analysis. Here we offer what is known as CMA. So CMA is for microdeletions. CMA is chromosomal microarray analysis, permits identification of these microdeletions and duplication. When CMA is used, a region of DNA that is missing or duplicated is termed as genomic copy number variants. So this is known as genomic copy number variants. A microdeletion or duplication may involve a stretch of DNA that contains multiple genes. This causes contiguous gene syndrome, which encompass serious but unrelated phenotypic abnormalities. In some cases, microdeletion may involve the exact DNA region that caused recognized microdeletion syndrome. When a specific microdeletion syndrome is suspected clinically, then we can confirm this either by using CMA or FISH. So in figure 16.6, a mismatch during pairing of homologous chromosomes may lead to a deletion of chromosome and a duplication of the other. So can you see this in meiosis 1? One chromosome is deleted from this region and duplicated to another chromosome. So there is deletion of this chromosome. This is normal. This is deletion. This is addition, means this is duplication, and this is also normal. So here is a list of selected microdeletion syndromes. Alagille syndrome. Here their location is 20p122. It is associated with cholestasis in the baby, that is paucity of intrahepatic bile ducts, cardiac disease, skeletal disease, ocular abnormality, and dysmorphic faces. So Alagille syndrome. Next is Angelman syndrome. Here there is microdeletion of 15q11.2 to q13, and this is associated with dysmorphic faces, also known as happy puppet syndrome or happy puppet appearance, intellectual disability, ataxia, hypotonia, and seizures. Cry-Du-Chat syndrome, deletion of 5p, abnormal laryngeal development with cat-like cry, hypotonia, intellectual disability. Kalaman syndrome, where there is deletion of chromosome number X short arm associated with hypogonadotropic hypogonadism and anosmia. Langer Gladion syndrome, 8q chromosome. Trichorhinopharyngeal syndrome, dysmorphic facies, skeletal abnormalities, sparse hair. Miller-Dieker syndrome, 17p, neuronal migration abnormalities like lissencephaly, microcephaly, and dysmorphic facies. Prader-Willi syndrome, 15q 11.2 q13, this is associated P for paternal. So here paternal genes are deleted, and obesity, hypotonia, hypogonadotropic hypogonadism, small hands and feet, and intellectual disability. Retinoblastoma of 13q where it is associated with retinoblastomas, retinomas, and certain non-retinal tumors also. Rubinstein-Tybee syndrome, where there is dysmorphic facies, broad thumbs and toes, intellectual disability, and increased tumor risk. Smith-Magenis syndrome, associated with dysmorphic facies, speech delay, hearing loss, sleep disturbance, self-destructive behaviors, and intellectual disability. Velocardiofacial syndrome, where there is conotruncal cardiac defects, cleft palate, velophalangeal incompetence, thymic and parathyroid abnormalities, and intellectual disability. Weger syndrome, where there is Wilms tumor, aniridia, genitourinary abnormalities, and intellectual disabilities. Williams-Borden syndrome, dysmorphic facies, dental malformation, aortic and peripheral pulmonary artery stenosis, intellectual disability. Wolff-Hirschhorn syndrome, where there is Greek helmet facies or dysmorphic facies, delayed growth development, cleft lip, cleft palate, colobomas, cardiac septal defects. X-linked ichthyosis, there is steroid sulfatase deficiency and corneal opacity. So these syndromes are associated with microdeletions, also known as selected microdeletion syndromes. So 22q 11.2 microdeletion syndrome. This syndrome is known as DiGeorge syndrome, Isfrentinsen syndrome, or velocardiofacial syndrome. It is the most common. So this velocardiofacial syndrome, also known as DiGeorge syndrome, Isfrentinsen syndrome, or velocardiofacial syndrome, most common microdeletion, prevalence is 1 in 3000 to 600 births, inheritance is autosomal dominant. So this DiGeorge syndrome, D for autosomal dominant. Offspring of affected individual have 50% chance of inheriting the syndrome. However, more than 90% of the cases arises from de novo mutation. The full deletion contains 3 billion base pairs, encompasses 40 genes including 180 different features. This is an emblematic of a contagious gene syndrome and poses counseling challenges because features can vary very widely even among family members. With prenatal diagnosis of an affected fetus, genetic testing is offered to the pregnant patient and her partner. Approximately 75% of affected individual will have conotruncal cardiac defect. So this DiGeorge syndrome is associated with conotruncal cardiac defects. What is included? Tetralogy of Fallot, truncus arteriosus, interrupted aortic arch, or VSDs, or ventricular septal defects. Immune deficiencies such as T-cell lymphopenia also develops in 75% cases. More than 70% have velopharyngeal insufficiency or cleft palate, and also certain facial features like short palpebral fissures, bulbonasal tip, micrognathia, short philtrum, small and posteriorly rotated ears, learning disabilities, ADHD or ADHD or attention deficit hyperactive disorders, autism spectrum disorders, intellectual disabilities are also common. Other manifestations includes hypocalcemia, renal anomalies, esophageal dysmotility, hearing loss, behavioral disorders, psychiatric illness, particularly schizophrenia. Now coming to chromosomal translocations. These translocations are DNA rearrangements in which DNA segments breaks away from one chromosome and attaches to other. The rearranged chromosomes are known as DER or derivative chromosomes. There are two types of translocations: reciprocal translocation and Robertsonian translocation. So what is a reciprocal translocation? Here a double segment or a reciprocal translocation results when the break occur at two different chromosomes and a broken fragments are exchanged. Each affected chromosomes receives a fragment of the other. If there is no chromosomal gain or loss, translocation is balanced translocation. Prevalence is 1 in 600 births. The carrier of birth balanced translocation will have a normal phenotype. However, repositioning of specific genes within chromosomal segments may cause major structural and developmental abnormalities in 6% of the individuals. Using chromosomal microanalysis technology, up to 20% of the individuals who appear to have balanced translocation are found instead of missing or redundant DNA segments. So here we find chromosomal balanced translocation using CMM. Balanced translocation carriers are at increased risk to produce unbalanced gametes. So these balanced translocated individuals produces unbalanced gametes and there is risk of abnormal offspring. So the children are affected. If an oocyte or sperm contains a translocated chromosome, fertilization results in unbalanced translocation, either monosomy in one individual and trisomy in the other. In general, translocation carriers identified after the birth of this abnormality is found after the birth of an abnormal child have a 50 to 30% Risk of producing offspring suffering with an unbalanced translocation. Carriers identified for other reasons, for example, infertility evaluation, only have 5% risk. This risk is lower because gametes are so abnormal that conceptions are non-viable. So here conception is also non-viable. This is balanced translocation carrier. This is normal individual. So these are the parents. So this individual is having balanced translocation or balanced reciprocal translocation, and this is a normal parent, suppose a male. So when gametes are divided, then there is chance of normal in one individual, balanced translocation carrier, and balanced duplication or deletion, and balanced duplicate. So 50% individuals are having 50% individuals are having unbalanced translocations or abnormalities with an affected offspring, and 25% individuals are normal, and 25% will have a balanced translocation as a carrier. Now coming to Robertsonian translocation, these involve acrocentric chromosomes. So what are acrocentric chromosomes? 13, 14, 15, 21 and 22. So these 13, 14, 15, 21 and 22. So this trisomy 13, that is Patau syndrome, and trisomy 21, that is Down syndrome, is also associated with Robertsonian translocation. Acrocentric chromosomes have extremely short P-arm, and P-arms contain redundant copies of genes coding for ribosomal DNA. In Robertsonian translocation, the Q-arms of the two acrocentric chromosomes fuse at one centromere to form derivative chromosome and other centromere. Both P-arms are lost. The lost DNA is present in multiple copies in the acrocentric chromosomes, and the translocation carrier is usually phenotypically normal. Because the number of centromeres determines the chromosome count, a Robertsonian translocation carrier have only 45 chromosomes. So these acrocentric chromosomes, so when translocation occurs, this arm is lost. So suppose two acrocentric chromosomes are there, and if they fuse and there is translocation, then this chromosome is made, and there is this chromosome also. So this is lost, and this is lost in some cells, and this is present in some cells. So patient is phenotypically normal, but we count because the number of centromeres determines the count. So centromeres are lost here, and only this chromosome is counted. So the number comes as 45 chromosomes. Balanced translocation. Balanced Robertsonian carriers have reproductive difficulties during fertilization. If the derivative chromosome pair will have normal haploid chromosome, the result offspring may have trisomy. So these individuals will have reproductive abnormalities. If the fused chromosomes are homologous, that is from the same chromosome pair, the carrier produces an only unbalanced gametes. Each egg and sperm contain either copies of translocated chromosome, which will result in trisomy if fertilized, and if no copy, then monosomy can also occur in such situation also. If the fused chromosomes are non-homologous, 4 of 6 possible gametes would be abnormal. Robertsonian translocations are found in 1 in 1000 individual. Risk is around 15% if a Robertsonian translocation is carried by the mother, and 2% if it is carried by father. So there is unequal risk. So if mother is affected, then 15% risk of transmission, and 2% risk if father is affected. However, Robertsonian translocations are not the major cause of miscarriage. They are identified in less than 55% of the couple for recurrent pregnancy loss. If a fetus or child is found to have a translocation trisomy, both parents should be offered karyotype analysis. If neither parents is a carrier, recurrence risk is normally low, extremely low. The most common Robertsonian translocation is DER 13, 14, Q10, Q10. So this chromosome is associated with Patau syndrome, and it is seen in 20% cases. Now what is isochromosome? When either P arms or either two Q arms from the same chromosome fuse together, an isochromosome results. This may occur if the centromere breaks transversely instead of longitudinally. So there is longitudinal separation, but if this occurs transversely during meiosis 2 or mitosis, alternatively an isochromosome can result from meiotic error in a chromosome with a Robertsonian translocation. If the isochromosome is acrocentric, composed of two Q arms, they will behave like a homologous Robertsonian translocation. Such a carrier is phenotypically normal but can produce only abnormal unbalanced gametes. The most common isochromosome involving long X chromosome is IQX, and this is seen in Turner syndrome. Now there is one term known as chromosomal inversions. When the same chromosomes break into two places, the intervening genetic material may invert before the break is repaired. Although there is no genetic material lost or duplicated, inversion may alter gene function. So there is abnormality in the function of the gene. So there are two types. There are two types: pericentric inversions and paracentric inversions. What is a pericentric inversion? This results from the break in both the P and Q arms of a chromosome such that the inverted material spans the centromere. So this inversion occurs near the centromere. A pericentric inversion causes problems in the chromosomal alignment during meiosis and confers significant risk for the carrier to produce abnormal gametes and abnormal offspring. The observed risk is around 5 to 10%. Risk is only 1 to 3% if prompted by another indication. An important exception is inversion 9 P11 11.2. This paracentric inversion involves 9 chromosomes, that is a normal variant, and present approximately in 1% of the population. So this inversion where this chromosome part near the centromere has inverted, and there is change in the function of the gene. So this is pericentric inversion, and if this occurs distal to the centromere, this is known as paracentric inversion. So pericentric inversion involves the centromere, whereas paracentric inversion do not involve. Individuals with pericentric inversion are at increased risk to have offspring with duplication or deletion. Those with paracentric inversion are at increased risk for early pregnancy loss. So paracentric inversion, if one arm of the chromosome suffers the two breaks, the inverted material does not include the centromere. So here same part it is affected, and here both parts around the centromere are affected, and the inversion is paracentric. The carrier makes normal balanced gametes. So in paracentric translocation, normal balanced gametes or gametes that are so abnormal to have preclude fertilization. Though infertility may be a problem, the risk of having abnormal offspring is low. So only this condition among your inversions, translocations, this condition with paracentric inversions may be having normal gametes. Then what is a ring chromosome? If the deletion occurs at each end of the same chromosome, the end can come together to form a ring chromosome. The telomere regions at the end of each chromosome contains redundant nucleoprotein complexes that stabilizes the chromosome. If only the telomeres are lost, all the necessary genetic material is retained and the carrier is balanced. If the deletion extends more proximally than the telomere, the carrier is likely to be phenotypically abnormal, and this is associated with ring X chromosome, which may result in Turner syndrome. So this is a ring chromosome. Now coming to mosaicism. Mosaicism is a condition in which the individual has two or more cytogenetically distinct cell lines that are derived from the single zygote. So there are some cells with normal genotype, and there are some cells which have abnormal phenotype. So though both exist together. Phenotypic expression of mosaicism depends on the several factors, whether the cytogenetically abnormal cells involve the fetus, part of the fetus, placenta, or some combination. Mosaicism is found in 0.3% of the amniotic fluid cultures. When abnormal cells are present on only single flask of amniotic fluid, this finding is called as pseudomosaicism, caused by cell culture artifacts. When abnormal cells involve multiple cultures, however, true mosaicism is more likely. Further testing varies. A single cell line is 60 to 70% of the fetus. Now the mosaicism is of two types: confined placental mosaicism, where mosaicism is found in placenta only, and gonadal mosaicism, where this is present in gonads or germline mosaicism. So confined placental mosaicism. Mosaicism involves gene abnormalities detected in 1 to 2% of the chorionic villi sampling specimens. Amniocentesis should be offered. So in such individuals, we offer amniocentesis. In a series of more than 1,000 pregnancies with mosaicism at CVS, subsequent amniocentesis identified true fetal mosaicism in 13% of the cases. Confined placental mosaicism accounted for 85% of the cases, and uniparental disomy, discussed later, was found in 2% of the cases. If mosaicism is detected for a chromosome known to contain imprinted genes such as 6, 7, 11 and 14, 15, testing for uniparental disomy should be considered, as there may be fetal consequences. Although outcomes with confined placental mosaicism are generally good, there is risk. So there is one risk associated with CPM or confined placental mosaicism, that is of FGR and IUD. Risk is still higher. Fetal growth restrictions may stem from impaired functioning of the aneuploid. So here placenta is affected, so there is impaired functioning of the aneuploid placental cells. In a recent series of 5,500 pregnancies undergoing CVS, the preterm birth rate of the pregnancies was 45%, 50% were small for SGA, small for gestational. Placental mosaicism for trisomy 16. confers particularly poor prognosis with as few as 1 to in 33 pregnancies with normal outcome. Now, what is gonadal mosaicism, also known as germline mosaicism? This refers to having one cell line in gametes and another in somatic cells. A genetic abnormality that is confined to gamete cells will affect all the cells of the offspring. Thus, gonadal mosaicism can account for apparently de novo disease. So, this mosaicism is not present in the normal somatic cells. This mosaicism is present in gonadal cells only, and when these gonadal cells form gametes, then this pass on to gametes, and when the baby is formed, this gonadal mosaicism can cause de novo diseases in the offspring of the normal parents. Because spermatogonia and duogonia divide throughout fetal life, spermatogonia continue to divide through adulthood. A meiotic error in the germ cells that was previously normal. New mutations identified in the offspring whose father is older than. So this is associated with age. Older than with father older than 40 years may rise through this mechanism. Gonadal mosaicism also explains 6% recurrence risk after the birth of the child caused by a new mutation. So there is 6. So these explains new mutation risk, which is around 6%. And this occurs in males with more not in females. This occurs in males more than 40 years of age. So here we have completed our disorders.